Everyone placing implants wants to achieve predictable single-tooth peri-implant aesthetics. So let's talk about John Kois and his 5 diagnostic keys. So John Kois in 2004 published this article in the compendium about attaining predictable single-tooth peri-implant aesthetics, and they gave 5 keys. The first is the relative tooth position, the second is the form of the periodontium, the thick or thin biotype, the different types of tooth shape, and also the position of the osseous crest. So if you look at the relative tooth position, you look in this case and tooth number 11 or tooth number 8, you'll see in this situation, if this tooth needed to be extracted and an implant placed, we have a very favorable gingival margin. We have a gingival margin that's actually more coronal. We know that when we extract a tooth and place an implant, we lose from 0.6 to 1 millimeter of that gingival height. So that gingival height will normally apically locate after you place an implant. So if you have a case like this and this tooth needs to be extracted and an implant placed, we have a very favorable situation because already in this case here, the gingival margin is more coronal. The relative tooth position is not just the apical coronal, but it's also the 3D positioning. And if you look at the left cone beam CT slice, you'll see that the tooth root is positioned quite labially, and you'll see a very thin buccal plate. And in a case like this, we know that when we extract a tooth, that buccal plate is very thin, and we know from a Rougeot study that that is most likely going to resorb, and you'll see this apical recession associated with the gingival margin. While the case on the right-hand side, you'll see the tooth itself is much more centrally located within the ridge, as well as the buccal plate is much thicker. In a case like this, when the buccal plate's thick of 1 millimeter or more, you have very minimal resorption of that ridge. The second key is the form of the periodontium. You know, the gingival scalloping. Is it a high scallop, is it normal, or is it a low flat scallop? In a case with very high scalloped gingival margins, carrying out implants in these sorts of patients has a much higher risk of having a black hole disease or missing gingival interdental papilla. So we have to be aware in a patient with a high scallop compared to a low flat scallop, they're a slightly less favorable situation and slightly higher risk. The third key is the biotype of the periodontium. Is it thick or is it thin? Patients, you've probably seen it in your own practice. In patients, you have thin biotype, really thin scalloped, high scalloped gingival margins. You carry out a crown preparation. It's very easy to see recession on these sorts of patients. And the same thing happens with implants. You see much more recession in those patients that have thin biotypes. And Evans and Chen has shown that there's much higher frequency of recession of 1 millimeter or greater compared to with thick biotypes. Some of you might ask, how do you classify biotypes? What's thick and what is thin? A thin biotype is basically when you place a probe in the gingival sulcus and you actually see the probe shining through the gingiva. So that is what we classify as a thin biotype, about 15% of the population. The fourth is the tooth shape. The tooth shape, is it square tooth shape or is it triangular tooth shape? A square tooth shape is certainly a lot easier to actually attain better aesthetics, whereas those with triangular tooth shapes have much more wider gingival embrasures, so the interdental papilla may be harder to fill a patient with a triangular type tooth shape. And the fifth is the osseous crest. The tissue is the issue, but the bone sets a tone. You heard that saying before. So if your osseous crest is very low, then it may be harder to attain good soft tissue aesthetics because the soft tissue is being supported by the foundation, which is the bone. So if we look at the 5 diagnostic keys, you'll see the favorable and unfavorable situations. And as dentists, we have some influence on how we can actually optimize and try and improve the biotype, how we improve the tooth shape. So if you look at here, the biotype, we may have a thin biotype. We can actually thicken the biotype by adding connective tissue. So some subepithelial connective tissue graft could be added to the gingival tissue to thicken the biotype. The tooth shape, you may have a triangular tooth shape. You may have some missing gingival tissue, missing interdental papilla. We might be able to add composite or ceramic in those regions to actually minimize and make the tooth shape a bit squarer, and also basically squeeze the papilla together. And obviously with bone grafting, we are able to improve the crest, improve the ridge, and maybe have a better support for our soft tissue. So Dr. Kois concludes his article by saying the predictability of aesthetic outcome may be determined by the existing anatomy rather than the clinician's ability to manage state-of-the-art procedures. So we know that sometimes, basically what he's saying here is that sometimes it's the foundations that we have, that we work with, not the actual clinician's ability. But as a clinician, we need to recognize when it's slightly higher risk. We need to be able to explain to our patients that this may not achieve the most optimal implant aesthetics in this sort of situation. What we might have to do is this procedure where we might have to add composite to the adjacent teeth. We might have to carry out some soft tissue augmentation procedures. Don't forget to like, share and subscribe, and I'll see you next time.